changing this up here. No? Correct. What was it? Fourth floor?
Video also going on.
Oh,
Oh,
that shooting.
Now, marketing team. I try to do it here.
Yes.
एक 2 मिनिटांमध्ये स्टार्ट करूया.
Oh.
संदीप सर.
Yes, Sunil, बोल.
संदीप सर स्टार्ट करावं का?
हो 4-5 ना स्टार्ट.
हां झाले. करू का स्टार्ट?
हो.
ओके. So here we'll go. Welcome all delegates. Again, one more lecture for this webinar series is by Rahul Yadav sir, and the topic also is very interesting: hypoxic respiratory failure. Today being a Maharashtra Day, Maharashtra Divas किंवा Maharashtra Day आणि कामगार दिवस. Very important sort of auspicious day for we people in Maharashtra, and we are lucky to have Rahul sir here today. He's though he is practicing in Chennai, I know his heart is here again, always at Maharashtra, and we are always lucky and happy to meet him at any forum, like at state, national level. He will be there always as a speaker. Again, this is very common phenomenon, respiratory failure in the newborn. And sir will just extrapolate what is happening, his experience about newborn, pediatric and newborn respiratory failure in COVID, and how to tackle it, manage it, and how to go ahead with it. Now, just a brief introduction. Rahul sir don't need actual introduction. You must have seen him in almost all the national, international platforms. Ever smiling, evergreen person of neonatology, and he's one of the first person in Maharashtra, one of the few people who started, qualified people who started neonatal practice. I heard a lot of interesting things about him. Like he used to be there 24/7 initially when he started practice in Maharashtra, and he was a very dedicated person. Later on, sir shifted to the Chennai at Kanchi Kamakoti. He's being to the professor and head of the neonatology at Kanchi Kamakoti, and even Ankur Hospital at Kanchi Kamakoti. And now sir is head of neonatology and perinatology division of Rainbow Children's Hospital. And if you just Google through his achievements, you will learn that he has done such a one of few tremendous, like Herculean tasks, like saving small babies from 400 grammars. Apart from his clinical and academic, after his DM and his practice, he has been to he's in research part also. He has done quite a number of research articles at national international journals, and He is editor to the few books also. So we're lucky, happy to have him on such an important date, that is 1st May, Maharashtra Divas. Rahul sir, we are really happy to have you here today. And lucky, and again request everyone, make use of maximum from this topic. Ask your question in question answer session, our chat box, and enjoy. Next 45 hours, you will learn a lot of things about respiratory failure. Sandeep sir, over to you.
It's indeed a honor and a pleasure to have with us Dr. Rahul Yadav. I know that he is Apla Manus, and today being an auspicious day,
Yes, totally agree, sir.
Kamgar Din and Maharashtra Day, we are indeed lucky to have Rahul with us. He has done his DM neonatology from Sion. Whenever we meet Rahul, we learn something new. There are quite a few good neonatologists around, but Rahul has his own unique style. He thinks differently, and whenever we meet him, we learn a lot of wisdom from him. So the way he approaches the problem, the way he tackles the issue, and the way he puts across the philosophy and wisdom, it's his unique style. So without wasting much time, we are all aware of hypoxia. We are all aware of oxygen requirements all over the country, and we know what the consequences of hypoxic respiratory failure are. So let's learn from Dr. Rahul Yadav today. Over to you, Rahul.
Thank you, Sandeep. Am I audible clearly? Am I audible clearly?
Yes, yes, perfect, perfect.
So today's talk is not about COVID. It is about usual hypoxic failure in newborn only, but with caveat of what we can learn from COVID-19. Last 2 years, we are actually among COVID-19. What are the new principles? Our old principles we rediscovered, and that we can apply to newborn practice. Those principles we are like to discuss here. So, what is this hypoxic respiratory failure? Everybody knows that. We'll focus on specifically 3 aspects about it. As I came to know, majority of our audience are already dealing with conventional ventilator, where we ventilated, extubated so many babies. So all of us, we have come across this peculiar situation at night that baby, once you put on AMBU bagging, baby improves, saturation goes up. Once you put attached to ventilator, saturation comes down. So this particular very frustrating situation. We do a lot of juggling around in settings, we increase setting, decrease settings, and this phenomena keeps on repeating itself. Ultimately, we lose the baby. So that particular focus, that particular specific focus we are going to focus today, that situation where AMBU bag is working, ventilator is not working. Second part is biphasic and triphasic worsening on ventilator. This is very common. Just like COVID-19, in newborn also, what we see is diaphragmatic hernia, we ventilate. Initially, we are very happy. On first day, second day, we are very happy. Third day, saturation comes down. The hypoplasia of lung, which was not there on first day, now it starts coming during counseling on third day. So we tell the family that the hypoplasia of lung is there, but it's not true. Something is happening. Something is happening. Initially improvement followed by worsening, again improvement followed by worsening. And this is a hypoxic respiratory failure. It happens with almost all PPHs we lose. Almost all diaphragmatic hernias we lose. Many times we give surfactant to the baby, and then baby becomes actually pulmonary hemorrhage. Hypoxia happens. Why it happens? Is there any way in which actually we can discuss it pathophysiology wise and practical guideline where we can identify pattern and we can actually chart it exactly where the baby is falling, and we can actually manage it quite accurately. And last is when to use nitric oxide and HFO. All of us actually are using ventilator. All of us want to use HFO, want to use nitric oxide. Once you start using HFO, initially we shift the baby to HFO and baby crashes. So how to anticipate that? What are the ways in which baby crashes after HFO and how to prevent that? That also we discuss. So this will be useful for those who are having HFO, not having HFO also. So all those parts we'll try to cover one by one. So before we go for that, first of all, we have to see about pathophysiology. Pathophysiology of pulmonary vascular resistance and hypoxia. That is the first part. Unless until we understand this thing, then next part will be difficult. So what is the pathophysiology of pulmonary vascular resistance and hypoxia? So for that, we have to understand what is acinus. Acinus is a part of unit of lung, gas exchanging unit of lung. As we know, the trachea bifurcates into bronchi, bronchi into bronchioles, then it goes for a number of bronchioles. Then comes what is called as terminal bronchiole. Terminal bronchiole, though it's called terminal, it is not terminal. Beyond that, there is a respiratory bronchiole. Now, what is the difference between respiratory bronchiole and terminal bronchiole? This is terminal bronchiole, this is respiratory bronchiole. This is only transferring the gas. Here is exchanging the gas. Now, beyond this terminal bronchiole, this respiratory bronchiole, alveoli, alveolar ducts, and all those things, that whole thing, the portion of lung distal to terminal bronchiole supplied by respiratory bronchiole, and that particular unit is called acinus. Now, this is the unit of lung where gas exchange is happening. So this, we will take it as a unit as acinus as unit. Now, once we go for next, this is very most important figure. Whenever you are ventilating a newborn baby or even adult also or child also, this figure we should not forget at all. But what is this figure? This whole thing is acinus. This whole thing is acinus. In between these empty spaces, white spaces are alveoli. They are full of air. And in the acinus, inside the acinus, there are intra-acinar vessels. Intra-acinar vessels. We can see these are small intra-acinar vessels. Now these intra-acinar vessels, they lack smooth muscles. They can't go for vasoconstriction, but they are susceptible for vasocompression. They can be compressed, but they can't constrict. This is a very important distinction. These intra-acinar vessels, they can get compressed, but they can't constrict. This neighboring alveolus can expand and compress it, but they don't constrict. Now, contrary to that, in between these acini, there are interacinar vessels. Interacinar, bigger one, they are having smooth muscle in the wall. Now, they can constrict. Whenever we are referring vasoconstriction, we are referring to these interacinar vessels. When we are referring to these are interacinar, they can constrict and they can compress. They can constrict, they can compress. Now, this constriction and compression, these are the two main mechanisms by which we get so-called pulmonary hypertension. So we'll go for next step now. Now, this is the next step. Now, we can see this is the usual acinus where these are the alveoli. These are the intra-acinar vessels. Now, what has happened because of over distension of this alveolus has become huge, big alveolus. And these huge alveoli are compressing the in between intra-acinar vessels. Now, this caliber of intra-acinar vessels are reduced due to over distended alveolus. This is called as gas trapping. Gas trapping. This is the way in which actually majority of our babies we lose. This is the time when it looks like a chakravyu. Means you are going into ventilation but can't come out. Slightest reduction of setting is causing problem. We want to reduce but we can't reduce. And these babies, they go for severe hypoxic respiratory failure. Second type we are seeing, this is the collapse. This particular acinus, whole acinus has become small. Now this acinus has become small. Caliber of intra-acinar vessels are maintained. These intra-acinar vessels have not changed here, but overall size has come. Now, what is the treatment for this? Treatment for this is reducing pressure. If you reduce this mean airway pressure, it will return the intra-acinar vessels to normal caliber. So now what you have discussed, we have discussed only about intra-acinar vessels. They get compressed. Even if acinus becomes small, they are retaining their same volume. Now we'll go to next part. Now these interacinar vessels, now we're focusing on these interacinar vessels. They are tortuous. They are like spring, coil-like. They are muscular. They undergo vasoconstriction. Now, what are the triggers for this vasoconstriction? Triggers are any sickness, hypoxia, acidosis, sepsis, pneumonia, recurrent respiratory syndrome. These are the triggers for vasoconstriction. Now, this acidosis causes vasodilation in systemic vessels, vasoconstriction in pulmonary vessels. Now, we get typical situation of hypotension with hypoxia in this situation. So, hypotension because of systemic vasodilation, hypoxia because of pulmonary vasoconstriction. This is how the terminal event starts. So, these interacinar vessels, they are tortuous, they are muscular, they can go for vasoconstriction. So, treatment here will be the vasodilators like nitric oxide. Now, let us come to the tortuosity of it. Now, let us see, these are the interacinar vessels. They start from A and end to B. Now, they're relatively straight. But if the AB distance is reduced, it becomes like more tortuous, more spring-like, more coily. Now, what happens is that the resistance offered by this vessel for the flow of blood increases. Small r becomes big R. That is the resistance, pulmonary vascular resistance increases. Now, this pulmonary vascular resistance increase, we are seeing three parts. One part is over distension, compression of intracinar vessels. Second is vasoconstriction of intracinar vessels. And third is increased tortuosity of intracerebral vessels. And these three are having entirely different treatment. Once you understand which type of resistance is there, then management becomes easy. So this is collapse of alveolus or collapse of acinus rather, and that collapse of acinus is increasing tortuosity, increasing resistance. Now this is commonly seen in collapse of lung parenchyma. Now this collapse can happen in pneumonia, it can happen in RDS, it can happen in foreign body. In pneumonia, more commonly it happens in RDS. Now the example we have seen pictorially is like a tent. This whole thing is acinus, suppose, and these are the ropes. Now suppose this tent collapses. Now these ropes, they get coiled, and this coiling of these interacinar vessels offers bigger resistance for this moving blood flow. So treatment will be sufficient recruitment. Here pressure is the treatment. Now we'll come to the fourth peculiar situation of different type of pulmonary hypertension. What is the pulmonary hypertension here? Here what has happened, this interstitial edema has happened. Now these are the alveoli, these are the intraacinar vessels, and this remaining interstitium is full of water. Water has come out. The water has come. This water has come from vessels. These intraacinar vessels have leaked, and water has come into this. We call this interstitial edema. Now, because of this interstitial edema, baby is going for hypoxia and acidosis. Now, what HFO does? HFO actually gives a lot of pressure into alveoli and drives that particular water back into these vessels. And then baby improves. Then another way is Lasix, but Lasix can lead to hypertension also. So there are 3-4 types we have discussed. Now we'll clarify it or conceptualize it. We'll have one simple formula. Whenever we say pulmonary hypertension, that is P, the pressure is increased. Pulmonary hypertension. It is a product of flow and resistance. So flow of blood and resistance offered to the blood by the vessels. Now there are many ways in which pulmonary hypertension increases. Pulmonary pressure increases. One way is vasocompression. This R has increased because of overstated alveolus. And because of this overstated alveolus, intraacinar vessels are compressed. Second, traditional way is vasoconstriction. Traditionally, it is described like this, vasoconstriction, where the vessel is constricting. And third is collapse, where the actually whole alveolus has collapsed. That's why R is increased. And a point to note is these three things are entirely different treatments. Here, more pressure, here, decreased pressure, and here, oxygen and nitric oxide, sedation paralysis. So, this particular 3 types of pulmonary hypertension, they behave entirely differently, especially in this case, in the case of collapse, more pressure is treatment. Here, reducing pressure is treatment. So, we have to clinically identify my hypoxic baby falls into which group. Fourth group exists. Fourth group, which is quite notorious. What is this fourth group? This is ASD, VSD, PDA, or as all of us have seen in COVID-19, rapid improvement of pulmonary vascular resistance. Patient is having vasoconstriction, and vasoconstriction has improved now. Baby was having vasoconstriction, the vasoconstriction has improved. Once vasoconstriction has improved, a lot of blood is coming to the lung. So this increased flow, this is flow related. So this increased flow or increased resistance can both 3 plus 1. There are 4 types of pulmonary hypertension. Now, conceptualizing it, this P is equal to flow is normal, R is increase. Enome can work. Here another P, R is normal, F is increase. HFO or Lasix will work. Both R and F is increase, HFO NO combination. So whenever we get a sick baby who is not improving, his saturation not improving, we are suspecting pulmonary hypertension. We have to try to fit into one among these 4 categories. Now it is very easy to say, but bedside is very difficult. So for that, we have prepared one chart for it. So this chart is quite big, so we won't go in detail. But overall, if we get this chart, actually, this chart I will send to you. So this chart will give one example. For example, here we see vasocompression, vasoconstriction, acinus collapsed and increased flow. Now here, these are the saturation behaviors. Here there are X-ray pictures. Here there are echo pictures. And here the settings which are there. Here is the blood gas and clinical features are there. So this chart I can share to you afterwards by email. But main example is here, all this we can see pulmonary hypertension, pulmonary hypertension, pulmonary hypertension. Echo will look same. In all 4 things, cardiologist will give you impression of pulmonary hypertension. Only thing he will say collapsed IVC in vasocompression. Here we are giving a lot of pressure. There is a delay in weaning. We are not weaning the baby properly. The delay in weaning itself is creating problem. Now this delay in weaning itself is creating problem. It is going big black lung. The lungs are big and black with very small heart, especially the right heart border. Right heart border is actually nothing but right atrium. The right atrium is compressed. So this particular right heart border is looking very straight. Big black lungs with small heart with straightening of right border. Initially saturations are normal or increase, but now later on decrease. This is called biphasic course. Maybe improved for 1 or 2 days, and after that actually without doing anything, actually saturation is coming down. This gas trapping is coming up. CO2 is normal, but later on it is increasing. Clinical features we see. What are the clinical features we see about vasocompression? In babies on ventilator. Babies being ventilated. Whether babies on ventilator, we are focusing on this upper part of chest. Now this upper part of chest, we are focusing for chest rise. Second thing, we are seeing at rest, at the end of expiration, how much is the bulge. Now this bulge should be seen from foot end. When you are seeing the bulge of chest, you should be seen from foot end. Whether this bulge is appropriate, is excessive, or is less. It is symmetrical or symmetrical. For the symmetry, we have to keep the head straight. If you turn the head to one side, the bulge becomes asymmetric. So at rest, how much is the bulge of chest, AP diameter of chest? And after ventilation, how much is the chest size? Typical classical situation in vasocompression, hypoxia, because of gas trapping, what we get is full chest. AP diameter is increased. AP diameter is increased and chest size has come down. So today we are ventilating the baby. Suppose chest is moving like this. If at all, this particular baby, we are not able to wean, gas trapping develops, then baseline fullness increases and chest size comes down. Full chest, which is moving less. Full chest, which is moving less, along with subcostal indrawing, along with some abdominal fullness and hypoxia, usually suggests gas trapping. It can be confirmed by X-ray, and this particular thing is something which is iatrogenic. It is not vasoconstriction, it is vasocompression. In this case also we'll get pulmonary hypertension. In this case we get big black lungs and small heart. This is just example. Similarly, other three like vasoconstriction, collapse of acidus, increased flow we can get. So all these things we can try to fit into one particular pathophysiology and then we can treat accurately. Scenario is suppose vasocompression. Treatment is very clear. Come down on pressures. Now come down on pressure is very easy to say, but if you try to come down, baby is becoming hypoxic because baby is precariously maintained. And this hypoxia created by us. We got into that chakra view. So how to go about that? Now pressure means what? We are talking about mean airway pressure. We are not talking about PIP, PEP. This mean airway pressure should be brought down. Now, easy way to do that is reducing rate rather than PIP and PEP. If you touch PIP, saturation comes down. And we know that gas trapping is there. So don't try to do something which is harming the baby. But here, if you reduce the rate, then we get a lot of E time, expiratory time. Once you get a lot of E time, then actually emptying of lung is facilitated. Gas trapping steadily comes down. Once reduce rate, then touch pressures, and then we can come out of the chakra. That is called gas trapping. Vasoconstriction. In this vasoconstriction, what happens is that this one is vasoconstriction, labile saturation. Saturation is labile. Once the baby activity, handling of the baby is crying, trying to cry, sedation comes down, the saturation is fluctuating. Slow saturation recovery. Recovery is also very important because this hypoxia can happen in bronchomalacia also. It can happen in pulmonary hypertension also. Difference between bronchomalacia and pulmonary hypertension is recovery. Recovery in bronchomalacia is quick, but in pulmonary hypertension it is slow recovery. So it takes long time to recover. This is typically vasoconstriction. Disproportionately low actually X-ray findings. Means what? This hypoxia is not matching with X-ray. X-ray is relatively good, but hypoxia is disproportionately severe. Examples we know that's underlying MAS, pneumonia, RDS, everything can be there. Pulmonary hypertension can be there. Adequate ventilated settings. We're actually giving good job of ventilation. CO2 is normal, but hypoxia is there. This is usually seen in vasoconstriction. So now this vasoconstriction, what to do? Vasoconstriction, as we know, sedation, paralysis, increasing oxygen, vasodilators are there. Now these vasodilators which are available, this one, they are double-edged paper. They dilate all vessels. Once they dilate all vessels, we end up into actually hypotension. Midrinone, sildenafil, they transiently improve oxygenation, but they can lead to systemic hypotension, which can be more difficult to manage. A hypoxic baby can be converted into hypoxic and hypotensive baby afterwards. So vasoconstriction is something which is treated by drug which is selectively effective for lung, that is nitric oxide. Nitric oxide is selectively acting only on lungs. It doesn't cause hypertension. So vasodilators can be used, increase oxygen, sedation, paralysis, and in some cases nitric oxide. Acinus collapse. In case of collapse acinus, what we get? In case of collapse acinus, what we get is here, this one. Saturation is lower. Small white lung. We get lung volume which is small and haziness is there. Pulmonary hypertension as usual will be there. Suboptimal settings. Sometimes we are afraid to cause trauma, barotrauma. So that because of that, we are using very minimum settings. So minimum settings that actually we are not actually treating the collapse properly. To prevent pneumothorax, we are suboptimal setting we have put. Here, usually CO2 is high. CO2 is high and PO2 is low. So in this situation, what we get clinically is that lot of intercostal indrawings. In spite of ventilation, in spite of so-called appropriate setting, we are getting lot of indrawing. Baby is breathing over and above the ventilator. I'll repeat, in gas trapping, what we got? A baby who is not breathing much, full chest, which is moving less. Now we got opposite, that is chest is small, AP diameter is small, lot of indrawings and baby is moving too much. We are actually very defensive in ventilation. In that case also, we can get picture of pulmonary hypertension because of collapse acinus, coiling of intracerebral vessels, and this sort of pulmonary hypertension. So in that case, what is the treatment? Recruit. We are having de-recruitment. This de-recruitment happens typically after suctioning. Baby is doing very well. After suctioning, baby collapses and takes long time to recover. So recruitment by increasing pressure. And best way to recruit is PEP, not PIP. It is PEP is the best way. So for gas trapping, best way to reduce gas trapping is rate. The best way to treat collapse is PEP. And last is increased flow. So when pulmonary hypertension was there, it improved rapidly and lung got flooded, and now we got pulmonary hypertension. Now we'll see when to start nitric oxide, because majority of us are having ventilator, but we are not having nitric oxide. So for starting nitric oxide, we have to shift the baby to some different center, and it takes some time. And during that transfer itself, baby worsens. By the time baby reaches that place, actually baby is further back actually. So when to start nitric oxide is this decision is very important. Now, traditionally it has been decided about oxygenation index. But this oxygenation index is not useful for actually the level 3 hospitals where they are not having nitric oxide, because this oxygenation index is a product of MAP and FiO2. Equal importance has been given to it, but practically it is not. MAP weightage is more than FiO2. Because of that, this another problem in oxygenation index is once you prick the baby, saturation comes down because of handling, and then deceptively low saturation comes up. So by pricking, the act of taking blood gas itself can actually exaggerate this need for nitric oxide. So what is the easy way to start NO? Easy way to decide about the time for starting NO, or we are referring the baby for nitric oxide. Is one thing is unnecessary, we should not refer. Many times we get reference for nitric oxide and this baby is improved just by changing the tube. It happens by suctioning. So why it happens? Because we are actually thinking of only one thing, that is vasoconstriction. When to start nitric oxide, first criteria is adequate lung expansion. There should be sufficient lung expansion. If you are not doing good job of lung expansion and saturation is less, effort requirement is high, means we are having suboptimal settings are there. There should be adequate CO2 washout, carbon dioxide washout. The carbon dioxide should be normal. If already CO2 high and hypoxia is there, that means CO2 shall be treated. For example, changing the endotracheal tube, suctioning the endotracheal tube, any pneumothorax to be drained. Hypoxia, despite 80 to 100% FiO2, no structural heart disease. When these four criteria are met, then you think about it. I'll repeat: adequate lung expansion, adequate CO2, hypoxia requiring 80 to 100% FiO2, and no structural heart disease. Now, which structural heart disease? Traditionally, we have seen that TAPVC is the one disease which actually confused commonly with pulmonary hypertension. So always make a point to ask the cardiologist to rule out TAPVC before thinking about nitric oxide, because once you start TAPVC and nitric oxide, baby worsens. Now, how to start nitric oxide? Nitric oxide is a very easy. As all of us we know, we are obsessed with 20 number. All our neonatology is 20 only. Phenobarb 20, phenytoin 20, dopamine 20, dobutamine 20, bilirubin 20, everything 20, 20. So this is 20 ppm. 20 ppm is traditional number. It is not fixed number. Some babies do require less, some babies require more. But traditionally, 20 ppm is something which is uniformly practiced. Some babies require more. See to it that this NO2 does not go beyond 2. NO2 is something which is being monitored here. This is 20. It should never go beyond 2. So we can start with nitric oxide of 20 ppm. Now, how to wean nitric oxide? Nitric oxide weaning is something which should not be guided by money, because nitric oxide is costly, oxygen is cheaper. Many times we end up reducing nitric oxide early, but it doesn't work out. Because why? Because nitric oxide and oxygen are synergistic. Nitric oxide and oxygen are synergistic. So here what we are seeing this example, just an example, FiO2 100%, nitric oxide 20. Initially, we started only reducing FiO2 only, 90%, 80%, 70%, 60%, 50%. Once you go 50, 60% of FiO2, then start touching nitric oxide, decrements of 2 to each, 18, 16, 14. Then once it reduces to 5, then we can think about stopping nitric oxide. Now, when to start weaning nitric oxide? Reduce lability of saturation. Saturation is very labile. In that case, don't touch nitric oxide. The saturation be stable and maintained. Reduce FiO2 requirement, and underlying cause should be improving. This is very important. Underlying cause. That cause can be meconium syndrome. It can be RDS. It can be sepsis. Nowadays, we are using more and more nitric oxide even in preterm babies also. So the underlying cause is improving. Oxygen requirement is coming down. Lability of saturation reduced. Then you start weaning NO. First wean FiO2 and then wean NO. And once you reach near 5, you can stop there. Now, another problem comes up. Previously, we were taught like this. Nitric oxide responders, nitric oxide non-responders. You give nitric oxide for half an hour, see for treatment. If there is no improvement, stop nitric oxide. These babies, in other words, were allowing the baby to die. So that was happening previously. Then later on, we understood that Indian scenario is different. Indian scenario is very different. Why Indian scenario is different is Western countries, the cause of pulmonary hypertension requiring nitric oxide is predominantly non-infectious. In India, it is predominantly infectious component is there. So this infection makes nitric oxide useless, apparently useless in the beginning, which becomes useful after some time. So these responders and non-responders, that distinction appears to be cruel. And sometimes we end up actually life-saving nitric oxide. Sometimes we are forced to stop. So what are the common causes of no response to nitric oxide, no response to NO? Commonest, as we already discussed, insufficient recruitment of lung. We are doing bad job of ventilation, under-ventilating the lung or over-ventilating the lung. Then nitric oxide doesn't work. Carbon dioxide is already high. We are not washing out CO2. Then also nitric oxide doesn't work. Active baby requires more sedation. In that case, sedation, then nitric oxide will work. And this is very important, underlying total anomalous pulmonary venous correction. So this underlying TAPVC is something which can mimic pulmonary hypertension. In experienced hand, it will be missed. So underlying TAPVC always rule out if nitric oxide is not working. And this is for India, underlying sepsis. Because this sepsis is the commonest reason why this nitric oxide doesn't work initially. After nitric oxide, saturation improves from 70 to 78, that's all. After it is not toxic at all. But with antibiotic and supportive care, this when sepsis starts reducing, same nitric oxide will start working, and slowly within 1 or 2 days, this so-called non-responder can become responder, and this baby can go home completely. Another thing is, last is refractory pulmonary vasoconstriction, uncommon. Previously, we are using this term very common, primary pulmonary hypertension, irreversible pulmonary hypertension, refractory. These so-called refractory, so-called irreversible are potentially actually reversible pulmonary hypertensions. Now, strategy. What is the strategy for non-responders? Suppose we start nitric oxide and baby is not responding, rule out causes rather than labeling into non-respondent, wait for resolution of sepsis. Now, another question comes up is, we don't have nitric oxide machine. We don't have nitric oxide machine, it is costly. We get nitric oxide, baby require nitric oxide very, very rarely. Why we should spend money in that? Usually hospitals are reluctant to share machines. Suppose if you call your friend to send nitric oxide machine, he said, rather than sending machine, you send the baby to me. So let us ship the baby to me rather than sending machines. This is what happens. So in that situation or some remote area where nitric oxide is not available, and in that area what to do? Because these babies were worsening. Suppose some town is there, MSP patient is there. They are having ventilator, but no nitric oxide. That the baby, by the time it comes to metro city, baby is quite bad. So in that situation, what to do? So this is the solution for that. What is the solution for that? It is nitric oxide given by flow meter, not by monitor. So this is not accurate. This is not to be recommended routinely. But in resource limited settings, suppose situation like this, nitric oxide machine can be, the cylinder is available. It can be carried quite easily by car also. And this flow meter, by flow meter, we can give nitric oxide. What is this flow meter? In this, we can see 0.2. This is 0.2 and this is 0. Here, this nitric oxide actually is 0, not going on. Nitric oxide we can give through flow meter, if you attach this 0.2 liter per minute flow of nitric oxide cylinder to inspiratory limb of the baby, then approximately more than 20, less than 25 ppm of nitric oxide can be delivered. Now this we are calibrated actually, we confirmed also. And we found that it is quite reliable, regular. We are using for more than a decade for many babies. But this should not be recommended as a first line. When there is no other go, when accuracy is not a requirement, but life-saving measures, emergency situation, transport situations, short-term delivery, when machine is not available, we can use nitric oxide in resource-limited setting without spending much money. This flow meter is costing only 8,000 rupees, rather than this big machine is costing 10 lakh rupees. So nitric oxide can be given to babies, those who need it, those who can respond it for short-term purpose, but this is not monitored. It can lead to toxicity. It has got side effects. Methemoglobinemia, pulmonary hemorrhage can come. So it should not be recommended routinely. Now, another controversial issue, preterm baby. Now, last century, we are using a lot of pulmonary hypertension in MAS. Then when this century started, first decade, it was MAS PPHN. A lot of babies started go up PPHN and all. Now, PPHN MAS has come down, but the requirement of nitric oxide by preterm baby has gone up. Why they are gone up? Because of IDM. If you get an IDM in front of diabetic mother with RDS, with PPHN, not responding to anything, severe hypoxia, and if you try to give vasodilators going for shock, these are the babies actually respond very well with nitric oxide. So nitric oxide average, the client of nitric oxide is changing. Previously it was post-term, then term, now near term and mild preterm. These babies do respond to preterm. Now, is it safe in preterm? Yes and no, both. Because these preterm babies, they have got hemodynamically significant PDA. They are already having left to right shift. Now, if pulmonary hypertension suddenly reduces, then lungs get flooded with blood, and there's sudden improvement of pulmonary hypertension causing pulmonary hemorrhage. So pulmonary hemorrhage is quite common if you give injudiciously nitric oxide to a lot of preterms. So there is a word of caution. So we should use it very sparingly in selected cases. When not to use nitric oxide, collapsed lung, don't use nitric oxide. Collapsed lung, babies hypoxic, first of all, expand the lung. High uncorrected CO2. Babies having tube lock, babies having underventilated lung. So adequate washout of CO2. Pulmonary hypertension due to PDA in preterm baby with left right shift, don't use this one. In that case, actually this particular nitric oxide will harm. And TABVC, don't use nitric oxide. Now we'll come to HFO. Even if you don't have HFO, you've got a lot of cases which are not improving with conventional ventilator, and we have to refer the baby for higher center for HFO. Even if you have HFO, what happens is that we buy HFO, and after that, after some time, many hospitals I have seen, they have stopped using HFO because of actually crash. The conventional ventilator baby is actually doing well, but not completely. We shift to HFO and baby crashes. After these 3-4 examples, actually we stop using HFO. So why it happens? And then to refer the baby for HFO, we'll see. What is the indication for HFO? It is variable. Some people do it early, some people do it late. In general, traditionally, MAP more than require 10 to 12. Now, some people go for it early, some people go for it late. In general, small white lung, in layman's words, small white lung means underventilated lung, hazy lung, all part of lung. No lung is uniformly black or white. We get a lot of white or black parts of lung. But predominantly, the haziness, that is collapse is the situation, and baby is not improving, hypoxia is not improving, then that is the case for HFO. And adequate monitoring. If this adequate monitoring is not there, then HFO actually can harm more than this one because it requires fine tuning. But once you learn that, your team learns that, is much easier than conventional ventilator. These are the various settings, and we won't go in detail. So HFO settings, many people think that HFO need is there, but they don't buy because they think HFO is very complicated. It is not complicated. HFO is much easier than conventional ventilator. What are this one? Here only 3 things are to be monitored, and 4 things are to be actually adjusted. Mean airway pressure, delta P, frequency, and FR2. These 4 things are to be actually adjusted, and only 3 things to be monitored: saturation, PCO2, and wiggle. Now this wiggle is something on HFO is equivalent to the chest rise. In conventional ventilator, we see chest rise, upper part of chest, we see up and down movement of chest. In HFO, what we see, in abdomen, we see wiggle. This particular baby is wiggling. This wiggle, we have to see 2 ways. One is up and down movement of anteabdominal wall, and we have to see the spread of wiggle. This spread of wiggle means sometimes the leg is shaking, ankle is shaking, knee is shaking, shoulder is shaking, like this. Horizontal spread of wiggle and vertical up and down movement of this abdominal wall. Now, this wiggle increase or decrease, that particular we have to train our sisters and yourself that wiggle is increased or wiggle is decreased, because that will give us a wealth of information. Now, how to go for it? HFO is much easier than conventional ventilation. Conventional ventilation, what happens? Once you change one setting, oxygenation and ventilation both are affected. But in HFO, both can be adjusted separately, completely separately. Ventilation means CO2, oxygenation means O2. It can be adjusted separately. How it can be adjusted separately? Let us see. Oxygenation, just keep a watch on saturation. And by saturation, adjust two things, MAP and FR. As simple as that. And ventilation, watch for wiggle and PCO2. Based on wiggle and PCO2, adjust delta P and frequency. This is very important thing, that separate adjustment of oxygenation and ventilation. Because sometimes we run behind CO2, O2 comes down. Run behind saturation, CO2 builds up. So that is avoided in HF, where we can separately adjust ventilation and oxygenation. Now, wiggle up and down wiggle will dictate the delta P, and lung expansion on X-ray will dictate the mean airway pressure. Now, there are two strategies about it, this HFO, or this is not about HFO also, in conventional ventilator also. There are two strategies where there are two types of people in the world. First, including all of us. Sometimes some people, related to antibiotic, related to inotropes, they give full support initially, and later on they come down. And second type of people, they gradually escalate step by step. That depends on their personality, that depends on their training, it depends on their personal experiences. As far as ventilation is concerned, these two strategies are equally effective once you understand the group in which. For example, in case of pulmonary hemorrhage, in situation like pulmonary hemorrhage, the strategy of giving full support initially for rapid escalation and then gradual de-escalation works. In case of pulmonary hemorrhage, same thing applicable to whiteout lung in RDS, complete whiteout lung in RDS, very severe RDS. This particular thing works. But in other cases like RDS, collapse, air leaks and all, the strategy should be gradual escalation and rapid de-escalation. So this particular strategy can be used. This can be used by HFO, this can be used for conventional ventilator also. So when you are ventilating, rather than deciding about ventilation alone, we have to fix the strategy in which we are going to plan this ventilation. This baby, whether I'm going to go full blast initially and then gradually I'm going to de-escalate, or whether I'm going to go for gradual escalation and rapid de-escalation. The strategy is fixed and communicate to the team. Then things happen quite easily, and barotrauma and under ventilation, both we can prevent this. Now, those who work with HFO, they know that once we shift the baby to HFO, suddenly baby crashes. What are the ways in which baby crashes? This one. So there are mainly three reasons why these babies crash. One is suboptimal MAP, where you use very less pressures. Second is where you use a lot of high pressures, and suboptimal delta P. Now, delta P related with ventilation. This is related with oxygenation. And these three types of babies, they worsen in a characteristic way. One type of baby becomes blue and then goes in shock. Second type of baby becomes pale, then goes in hypoxia. Third is pink and then goes for shock. So in critical illness, this is applicable to even conventional ventilator also. Now we'll go for third first. This is the deceptive baby. Here, where the baby is actually pink and this baby is actually worsening rapidly. Why it happens? Suboptimal delta P or suboptimal ventilation, carbon dioxide buildup, respiratory acidosis develops. This acidosis has got effect on vessels. It leads to vasodilation. Because of vasodilation, baby is appearing deceptively pink. A pink baby goes for shock. That we call as warm shock. This particular thing happens because of underventilation. Second happens because of gas trapping, where excess MAP has been used. Sudden gas trapping has happened. Now, because of this gas trapping, reduced venous return has happened. Now, reduced venous return happened, then baby goes for shock. But this shock is usually because of less blood coming to the heart. That's why less blood being pumped by the left ventricle. It is initially compensated by vasoconstriction. These are pale baby. They become pale first. Pale and then they become hypoxic. And this is quite common where lungs are collapsed, de-recruited, respiratory acidosis, cyanosis and shock. So there are various ways in which baby crashes. So whenever we lose any baby in NICU, rather than thinking socially, economically or something, next day we have to rewind. We have to find out how the colors change and ultimately we lost the baby. And we'll find that this baby falls into one category. Either we give less pressures, or we give more pressures, or we give less ventilation. So which category was the repeated causes of deaths in our hospital? We have to identify and change the strategies. Now, how to shift the baby to HF? First of all, we have to review X-rays and blood gas, correct metabolic acidosis, well-fitting ET. This is very important because what we observed is this well-fitting ET is a problem. The problem is in our charts where the ET size has been selected by gestational age and weight, which is untrue at all. The endotracheal tube size is not depending on weight, birth weight at all. It is hard to believe that when baby is born, first we'll weigh the baby and intubate. It won't happen. We can't weigh the baby before intubation. Similarly, gestation doesn't dictate the ET size. ET size is based on actually caliber at all. So once you see the glottis, then we have to see 2 number ET, 2.5, 3 number. All those things should be decided on the spot. So many times predetermined, we decide that this baby we are going to intubate with 2.5. We intubate with 2.5. And then we wonder why the baby is not improving. Or initial improvement, why saturation is not improving. Easy way to diagnose this is by seeing the peritubal leak. The peritubal leak, once the baby is already intubated, see to it, just put your finger on the neck anteriorly. Once you put the finger on neck, with every breath of ventilator or ambu bag, we can see curr sound is there. Sometimes we can put stethoscope on this neck, anterior part of neck, and we can hear the peritubal leak. Now this peritubal leak is not abnormal. Peritubal leak is actually, some people welcome that because it will help in reducing the trauma. But in hypoxia is there, CO2 buildup is there, baby is not improving. This peritubal leak can be the cause. Whatever we are doing by ventilator is actually being lost. And whatever machine is showing, it may not be accurate, that percent leak at all. So if you clinically find that there is peritubal leak, there is actually auscultable sound is there, crunching sound is coming up, then just ET change can be actually game changer. Once you change the ET, baby starts improving rapidly. So don't ignore this ET size. ET size is individual, and with time, the requirement of ET size increases. Suctioning of ET. Review settings in past, formula strategy, hand back to just compliance, and then observe, adapt. So this will, we can shift the baby to HF4 next step. Now, what is optimum MAP concept? This optimal MAP, let it be HF4, let it be conventional. This pressure, the optimal MAP is a imaginary number. That number is never fixed, it keeps on changing. What is the MAP? Is minimum MAP, which reduces FR2 requirement, which corrects blood gas without causing shock, without causing overexpansion. This is a very important thing to understand. For example, I'll give one example. There's some babies there, preterm RDS baby is there. We are ventilating the baby. MAP of suppose 10. Very high requirement is there. FR2 requirement is 80%, 90%. Whenever you try to reduce FR2, baby is actually coming down. That means not a good situation. That means something is wrong. Either baby requires second dose of surfactant or some setting problem or airway problem. So always think whether that pressure we are giving, is it optimum or not? Optimum MAP is a minimum MAP, which facilitates reduction of FiO2, which corrects blood gas without causing shock, without causing overexpansion. That margin of safety is actually ensured by this optimum concept, optimum MAP. Now, at the end, I would like to say these two things. It is quite peculiar thing, this one, where there's time has come to say goodbye to two terminologies. Now, can you say goodbye to some disease? So can some disease die? Can some disease disappear? Smallpox has disappeared because of vaccination. Polio has disappeared because of vaccination. But some diseases have disappeared without vaccination also. Classical example is all of us when we were doing PG at that time. Indian childhood cirrhosis was a common disease. And we used to present cases on that, Indian childhood cirrhosis. What was the criteria? Baby is in India, baby is a child and he is having cirrhosis, Indian childhood cirrhosis. That whole disease went away. So that many diseases. Another thing is mitral valve prolapse, MVP. It was a very popular diagnosis a few years back. Nowadays, they are not diagnosing as a disease. It is considered some normal variation. Mitral valve prolapse, Indian childhood. Some diseases actually there's some they disappear. Similarly, these two diseases are there, or these two terminologies are there. We are used very often when actually we are actually unable to treat the baby. We use these two terminologies commonly to counsel the families and counsel each other and console yourself that this baby is having hyperplasia of lung, or this baby is having irreversible pulmonary hypertension. So-called hyperplasia of lung, so-called irreversible pulmonary hypertension actually are potentially reversible. So now it is hypoplasia of lung. Whenever you get small lungs with CO2 buildup and saturation not improving, let it be pulmonary hypertension. Along with that, then we label it as a hypoplasia of lung. Hypoplasia of lung can't be diagnosed by X-ray. Hypoplasia of lung can be diagnosed only at autopsy. In autopsy, if you allow the lung to float in water, whether it's floating or sinking in water, that is the crude test for hypoplasia, macroscopic test. Microscopic we can see afterwards. So this hypoplasia of lung don't label for underventilated lungs. If a baby is having low volume lungs and saturation is coming down, and baby is having pulmonary hypertension, this baby is in need of better ventilator strategy rather than labeling it as a hypoplasia of lung. Same thing applies to the irreversible pulmonary hypertension. So-called irreversible pulmonary hypertension can be actually reversible. We have to find out why it is not responding and what are the causes, and all causes we have to rule out. Don't label that particular baby to be irreversible or primary or idiopathic pulmonary hypertension too premature. So summary of the talk. Summary is quite simple. There are four ways. There are four ways in which pulmonary hypertension develops, not one. Previously, we focused only on one, vasoconstriction and vasodilation. But no, pulmonary hypertension happens in four ways. One way is vasocompression. Here is iatrogenic pulmonary hypertension. We have ventilated baby so much that biphasic worsening happening. Initially, it responded, and now it is again going for hypoxia. Over distension of alveolus and compression of these intra-acinar vessels. And this baby is going for hypoxia, pulmonary hypertension is coming up. Your treatment is reduced pressures. Second is traditional vasoconstriction, MAS, PPH, and diaphragmatic hernia, PPH, and acidosis. In that case, vasoconstriction is happening, and then nitric oxide works. Collapse, where specifically after suctioning or under ventilation, the lung volume itself is low. Because lung volume is low, the pulmonary vascular resistance has increased. In that case, either conventional with higher settings or HFO with optimum map treatment. And last but not the least is congestion, where pulmonary hypertension was there. It improved so fast. For example, condition was like this. It improved so fast that now we are having pulmonary congestion. And this pulmonary congestion, increased flow is there, and that is giving appearance of pulmonary hypertension. But it is not because of increased R, it is because of increased F. In this situation, HFO with less FiO2 and optimal MAP. This biphasic, triphasic worsening all around we are seeing even in COVID-19. In COVID-19 also we get all these patterns. It is actually quite evident that initially patients are having pulmonary hypertension, they are having pulmonary congestion, they are having alveolar collapse, and they are actually having all the complications. So these things we have to learn from this one. Ultimately, what are the greatest teachers in our life? Whatever mistakes we ourselves do, errors we have to do, disaster we face. So these are the three teachers in life. Problem is we should learn from them. Usually we try to forget them, but all the babies we have lost in our career, if you remember, if you rewind, and what went wrong, if you analyze, you will be surprised and sad to know that majority of deaths were preventable. Majority of deaths happened because either we over-ventilated, under-ventilated, or we had a different strategy. And the strategy was the problem, not the machine or not the man. So let us learn from this, all mistakes, errors, and disasters in life. Let us improve our outcomes about hypoxic respiratory failures in newborn. Thank you. Thanks a lot.
Excellent, Rahul. As always, it was absolutely spot on. And as I really said in the beginning, that whenever we hear, we get a lot of wisdom. And you have a unique style of explaining us this in a very different manner, which we would remember for rest of our life. I think we have a couple of questions for you. The first question is by Dr. Abhasai Patankar.
Yeah.
Sir, as you gave example in the beginning, baby is not desaturating on AMBU bag, but worsens on ventilator. How does one deal with this unique problem?
Yes. Yeah. This slide I forgot to prepare actually. This is a situation. Now, this is a common situation faced by all of us. We are bagging the baby, saturation improves. Once you attach the baby, the ventilator saturation comes down. Now here we have to understand what is the difference between AMBU bag and ventilator. In AMBU bag, the usually PEP is 0. And then ventilator PEP is something, 3, 4, 5, 6, something is there. So PEP is 0. Second thing is, here AMBU bag, I time is prolonged. I time is more than 0.3, 0.4 what we are giving this one. Another thing is, this AMBU bag, we are automatically adjusting based on compliance of the lung. The ventilator is not adjusting. And respiratory rate, usually after some time, is actually less. Less rate, more I time, 0 PEP, and adjustable PIP. This is the hallmark of AMBU bag. AMBU bag is the best ventilator in the world. Now, what are the reasons? When we bag the baby improves, put on ventilator, baby worsens. Commonest reason we found is peritubal leak, tube kink, tube block. So partial tube block, peritubal leak, and tube kink. These are the three common reasons of this situation. Fourth common reason is, as we said, this is pulmonary hypertension. Baby is having pulmonary hypertension. This pulmonary hypertension is being overcome by bag. Once we attach this one. Fourth common reason is suboptimal setting on ventilator. Our settings are less than optimal, this one. Another thing is gas trapping. Another thing is PIE, pulmonary interstitial emphysema, where this PEP, what we are giving itself is causing PIE, and this cuff of air is throttling itself. During inspiration, that air in the air inside the airway actually going out around the airway, cuff is forming and it is throttling, as if the airway is committing suicide during this one ventilation. That is PIE, pulmonary interstitial emphysema. But in AMBU bag, the PEP is 0, so that outside air actually comes out, comes inside, and baby improves. So these are the common reasons. I will repeat: peritubal leak, tube kink, partial tube lock, PIE, pulmonary hypertension, suboptimal settings on ventilator, and terminal stages. These are the few reasons of baby improving on bag, not improving on ventilation. We have to rule out all causes, and then we have to treat them.
Excellent. Again by Dr. Abhasai Patankar, in a case of pulmonary hypertension, according to you, one not responding in spite of all the possible things, then what you label it as, or you feel is still undertreated.
So this one is commonly we talk with each other. We have tried this, we have tried this, we have tried this. So in spite of that, baby is not improving, means this particular thing is irreversible. So usually what happens is that many times we think about treatment. Means we have tried nitric oxide, we have tried bosentan, we have tried sildenafil, we have tried bicarb drip, we have tried overventilation, we have tried Belerian. So we enlist usually number of treatments. Usually what happens in this situation is this so-called irreversible pulmonary hypertension is the commonest reason of this one is underventilation or overventilation. CO2 should be normal. Now, before labeling this as irreversible, CO2 should be normal. X-ray should be reasonably expanded. The X-ray, reasonable expansion of X-ray, CO2 normal, then ruling out sepsis. Sepsis we can't rule out actually in any Indian sick neonate. So underlying sepsis is commonest. Repeat echo by some other person to rule out any structural heart disease. Underlying polycythemia, underlying uncorrected acidosis. So underlying hypoglycemia, hypocalcemia. So these are the various reasons of pulmonary hypertension. Recently, we got one case, a very interesting case of infant. As we said, so-called irreversible pulmonary hypertension turned out to be simple thiamine responsive encephalopathy. Once you give thiamine, pulmonary hypertension improved dramatically in half an hour. Lactate was 20, which improved to 2 in 24 hours. So today's irreversible can be tomorrow's reversible. So all the possibilities of this so-called irreversible has to be ruled out. So commonest reason is underventilation, overventilation, sepsis. But rarely we get thiamine responsive encephalopathy, and pulmonary hypertension drastically improved. Baby came out of NO within 1 day. So there are so many causes where actually we can make a difference. So this domain of so-called irreversible pulmonary hypertension has to contract, but it should contract first in mind, then it will contract then in ICU.
Right. Excellent. So I think we need to ventilate at FRC, and we need to correct the underlying metabolic derangement.
Yes.
Is the best pulmonary vasodilator that we have in our armamentarium.
Yes.
There's one compliment, Rahul. Dr. Kishore Sanghvi sir says that we love to listen to you, absolutely down to earth and clearing the basics. And I really agree 100% with Sanghvi sir that whenever we listen to you, we learn something new.
Thank you, sir. Thank you, sir.
Dr. Prashant says, can you please explain the concept again? Respiratory acidosis in suboptimal MAP versus suboptimal delta P causing cyanosis versus a pink baby going on to shock. So I think we are talking of high frequency ventilation.
Yes. So this one, this particular thing is, this one is once you put the baby on HFO, baby crashing, there are 3 scenarios we discuss. First scenario we discussed is when we are using, suppose previously baby is on conventional ventilator, he is requiring MAP of 12. Now rule of thumb says that add +2 and then ventilate for HFO. Means conventional ventilator is requiring MAP of 12, we go for MAP of 15. Now this 14 to 15 is arbitrary figure that we have to understand. Suppose baby requiring 20 and we are giving MAP of 14, then there will be actually full crash. The alveolus will collapse after HF. Suboptimal. In that, once this particular crash happens, then this particular baby is going to have severe hypoxia. This baby will go for cyanosis and along with acidosis. So this baby will become blue and then they'll go in shock. Suppose baby's requirement is only 15 and we are giving very high maybe 18, 20. In that case, gas trapping will come. And because of gas trapping, venous return from all the body to heart is baby will go in shock, pale baby. Suppose baby's requirement of delta P is high. He requires 30, but we have kept only 20. Wiggle is very less wiggle. In that case, sudden respiratory acidosis will come. Baby will remain pink, but will go in hypotension. Pulses are not fed. So, in other words, we have to formulate our strategy. When you are going for HFO, we have to think whether we are going for this baby is prone for which worsening. Suppose baby is already having gas trapping and all those things, and we are going to trying to HF oscillate. The chance that this baby will have actually shock afterwards. So anticipating these three types of worsening will prevent majority of problems.
Can you please explain the recruitment of lung on HFOV with respect to intra and interacinar vessels and the size of the alveoli?
Yeah. So this one, recruitment concept is used for actually whatever available gas exchanging area is there is available or not. Gas exchanging areas means alveolus. Suppose you imagine all the alveolus are actually open, then all gas exchanging areas are available. Suppose this area is not available, some alveoli is collapsed, some are this one expanded, then this gas exchange available units are not available. Recruitment means what? Using that particular thing, recruit that particular acinus or alveolus, we are recruiting, means we are utilizing that. De-recruitment means what? These alveolus are collapsed, and re-recruitment means what? Was expanded. Now, this recruitment applies to the alveoli, and these vessels are different. Suppose if you oscillate the baby or ventilate the baby with very high pressures, the alveoli is so big, this in between two alveoli, that there are intracinar vessels, and that is this one, and these vessels get compressed. Now we get biphasic course. We get a big black lung with small heart, and saturation again starts going down. Once you take the baby on back, baby is improving. Once you put on higher setting again, baby starts going down. This is typically seen in over-recruited, over-distended alveolus, gas trapping with iatrogenic hypertension, pulmonary hypertension. This iatrogenic hypertension we can prevent by timely weaning of ventilator.
Dr. Gaurav wants to know what are the contraindications for a nitric oxide.
Yeah, ideally there are no contraindications actually. There are no contraindications for nitric oxide. Nitric oxide can be used in almost all cases of pulmonary hypertension because of vasoconstriction. This is when we use nitric oxide in other conditions. For example, when they actually pulmonary hypertension is because of collapse, nitric oxide doesn't work. When high CO2 is there, already collapsed alveolus, surfactant is not given, polycythemia is not treated, preterm baby with PDA, left-right shunting, underlying heart disease. These are the relative contraindications where nitric oxide should not be used. Otherwise, there is no absolute contraindication.
So I think the message that you want to give us is that don't start nitric oxide as first drug in a baby with PPHN. First do your basics, right?
Yes.
Escalate at FRC, correct the metabolic derangements, maintain normal temperature, sugar, and then if the baby is not responding, then maybe you can think of other modalities of treatment in management of PPHN.
Correct.
There's one more question by Dr. Jayesh Singh. Sir, some babies initially respond to hypoxia and slow decrease in SpO2 and finally collapse, especially babies with severe sepsis.
Yes. So here is a very important. Initially respond and slowly start coming down. Now this going down, this hypoxia, this one, what happens is that every hypoxia we have to divide into two groups. Whether it is because of VQ mismatch or is because of hypoventilation. When saturation is low, always we have to repeat blood gas and X-ray. If blood gas is showing CO2 buildup and hypoxia, that means our job of ventilation is not done. What happens is that our brain has been trained for that terminology, ventilator. Ventilator is not oxygenator. Ventilator is for ventilation only. So ventilator settings are predominantly for CO2. It is not for saturation. This particular mentality we have to change in sisters and our team. Many times what happens, ventilator we are changing for saturation, which itself is wrong. Ventilator is for ventilation. Oxygenation is a byproduct. Now, if saturation is coming down, ventilation is less. That means CO2 is high. That means some other cause is there. Maybe tube block, peritubal leak, tube kink is there, or suboptimal setting, developing collapse, developing air leak and all those. That we have to treat. Once you treat that, automatically saturation will go. Suppose we are having this gradual coming down, adequate this one ventilation, then we have to think about pulmonary vasoconstriction. Suppose gas trapping is developing. Commonest reason here, what we're describing is looks like gas trapping. Delay in weaning of setting itself causing gas trapping, and gas trapping itself causing hypoxia. So the delay in weaning, where the timely weaning is not done, then commonly we get this situation. Gradually saturation starts coming down and it becomes irreversible.
Question from Dr. Pradeep. I think he's from Tirunelveli.
Tirunelveli from Tamil Nadu.
Yes, close to you.
Yes.
Your experience on sildenafil and milrinone in severe PPHN with LV dysfunction, where we don't have nitric oxide. I think we all know hypoxia and LV dysfunction. So how will you, which drug will you prefer, milrinone or whether sildenafil?
Yeah, here is the problem with the, both these drugs can lead to hypotension actually. So milrinone or sildenafil should not be used when hypotension is possible. Now we do never know hypotension is possible. Because drug response dose relationship is not linear here. Many babies that tolerate these drugs very easily, and some babies with low dose also they go for hypotension. So how to know that this particular baby can go for hypotension? Those who are already gone in hypotension, those who are already on inotropes, in those cases, sometimes once you use IV sildenafil, IV this one milrinone, they go for hypotension. Now how to predict these? One is echocardiography actually can pick up this ventricular dysfunction. Now I fully agree with him. The nitric oxide is not available. Baby is having pulmonary hypertension, not responding to usual, and we want to use some vasodilator. So now we have to understand this sildenafil and milrinone, how they cause hypotension. They cause hypotension by acting at arteriole. Now this arteriole dilates. Now this arteriole dilates, hypotension we have to prevent. How to prevent hypotension? By improving the stroke volume. Now how to improve stroke volume? We have to use a drug for left ventricle which will not cause pulmonary hypertension. That drug is dobutamine. So if you prime the baby with dobutamine, if you improve ventricular contractility, and then very judiciously we go for milrinone or sildenafil, they can tolerate, and without hypotension we can treat. So dobutamine used for as an inotrope, improve BP, see the BP is stable, and then you go for milrinone and sildenafil. Dopamine high dose can act on pulmonary vessels also. Dopamine high dose can actually contribute to pulmonary vascular resistance. And in peculiar situation of pulmonary hypertension with systemic hypotension, systemic BP is low and pulmonary BP is high. In that case, drug of choice can be vasopressin. Vasopressin can use miracles in this. Vasopressin baby improves drastically. Vasopressin does not cause pulmonary hypertension. So systemic hypertension, vasopressin. Systemic hypertension, in that case, we can go for milrinone or sildenafil primed with dobutamine.
Excellent. So I think we are done with the questions, or there's one more question. Yeah. From Dr. Prashant, flow meter of nitric oxide, is it compatible with hybrid or HFOV ventilators? How do we know 0.2 is equivalent to 20 parts per million?
Yes. So first part is yes. This particular flow thing can be used with HF also. HF also we have used. Second part is guesswork. But what we did here is that we found the formula for ppm. What is ppm? Parts per billion. And we found that flow of the gas, whatever flow is generated by ventilator, what is generated by that machine, which is mixing, and then we are getting that particular output of ppm. And that flow, we actually extrapolated this. It is not actually accurate. It can't be proved or disproved. So this particular situation, sort of this 0.2 liter and all those things should not be actually encouraged routinely in those situations when routine machine is not available, or for short term, when machines are short. In that case, we can use. But once you start using it, actually it can save plenty of lives. But this is not accurate.
Right. So I think we have no more questions. So as always, Rahul, it was wonderful listening to you and your wisdom. So I'm sure a lot of people would manage hypoxic respiratory failure. And I'm sure there's a combination of art and science, which you have told us in the last 1 hour, how to make use of art as well as science in judicious and correct management of a baby with hypoxic respiratory failure. So on behalf of the state NNF, Sunil, and our team, we would like to thank you for your time, efforts, and lucid presentation. And we wish you election results are there, so I'm sure tomorrow you would be busy with the results from the Chennai elections.
Thank you very
so
much. Thank you.
Namaskar.
Namaskar.
Kansham, thank you very much.
You're welcome, sir. Thank you.